Okay, welcome everyone. My name is Shirley, and I will be your moderator this evening. Tonight, we are so lucky to be joined by Dr. Basem Abdelmalak, Professor of Anesthesiology at Cleveland Clinic Larner College of Medicine, and he's going to share about the top safety strategies for airway management in non-operating room anesthesia locations. If you guys have any questions, we're asking you to please type it into the Q&A box, and we're going to address those questions at the end of the webinar. BE is not available for this webinar live or on demand, but we will be emailing this out, tonight's recorded conversation, in the next week or so to everyone who has registered. In the meantime, I'll welcome Dr. Abdelmalak, and thank you for being with us tonight. I'm going to pass it over to you now.
Thank you, Shirley. Appreciate that. And thank you all for joining us tonight for this interesting and exciting webinar. I'll be happy to discuss all those safety strategies for airway management and non-operating room anesthesia. So my objective for tonight, we're going to discuss the following: the critical role of monitors and anesthesia machines in non-operating room anesthesia, how to leverage high-flow nasal oxygen in high-risk and complicated airway procedures. We're going to talk also about common gaps in monitoring practices and how to minimize preventable respiratory complications in NORA, and also best practices and precautions in airway management for high-risk patients. So before we start, I'd like to disclose conflicts of interest. I am a speaker for Medtronic, Acacia Pharma, and Mindray North America. Mindray North America is the one sponsoring tonight's webinar. I also happen to be honored and privileged to serve as the president of the Society for Ambulatory Anesthesia, where NORA is in our logo, and currently serve as the chair of the ASA Task Force on NORA and Procedural Sedation. So let's start with definitions, so we all be on the same page what we're talking about. When we talk about NORA, the official definition as it comes from the ASA statement as such: care provided by anesthesiology personnel for inpatients or outpatients undergoing diagnostic or therapeutic procedures performed at locations outside an operating room pavilion, but within the hospital. So we're not talking about ASCs or office-based anesthesia. When the word NORA is mentioned in my presentation, it refers to those locations, which in the past we used to call them remote locations, which a term that didn't receive popularity or did not catch on, but now NORA is catching on, and people seem to like this definition. However, some of the principles I'm going to be talking about actually applies to office-based anesthesia as well as ASCs and main operating rooms as well. Well, we all noticed that there has been a tremendous growth in NORA. The last data that was published that we have was in 2017. Actually, the data is from 2014. It shows in the left upper corner here that NORA services constituted about a little bit more than 35% of anesthesia services at that time. Actually, now with the expansion in NORA and everywhere, it's about 50% of what we do, believe it or not, is NORA services. And I don't think two of you or three may not disagree with me that it is actually the most inefficient service. That's one of the complexity and challenges we have in NORA. This is the list I summarized for the different challenges and complexity in NORA: space and equipment, staff, patients, procedures, quality and safety, efficiency, and finances. The problem with efficiency has gotten so bad, especially nowadays with the issue that we're all facing, shortages in anesthesiology personnel, anesthesiologists, CRNAs, CAAs. We do not have enough of anesthesiology personnel to provide the services that we need for our patients. Hence, the ASA formed this summit for workforce shortages, out of which 4 task forces were formed. I was privileged to lead the task force on NORA and procedural sedation. And one of the first things that we worked on as a task force is to revise the very old statement on non-operating room anesthesia locations. And now we made it into a bigger document that has a lot of good hints and concepts and ideas for how to manage anesthesia services, as this has gotten so big and so advanced. So this new document catches up to the current practice and helps us manage all these locations with all the challenges that are there. I encourage you all to download this document and review it. And if anybody needs a copy, I'm happy to send it to you. I have my email at the last slide of this webinar here today. So I just picked up a few items to highlight today related to our topic in terms of safety, and especially airway safety in NORA. First of all, the task force recommends that the Director of Anesthesia Services at a given hospital need to be involved in planning and establishing NORA services. As we all know and see, that NORA is expanding everywhere, so no doubt that many hospitals are now either remodeling an existing location or building a whole new location, and that is our opportunity to get involved, starting from the blueprints to help shape the new NORA location where we can provide safe services, and request and demand a business plan before you start this kind of endeavor. Business plan that includes the purchasing of a modern anesthesia machine, the anesthesiology monitors and equipments that we could possibly need, maybe a medication machine like a Pyxis or Omnicell or something like that. Any equipment that you could possibly need and monitors that you would possibly need in this NORA location. And when you do that, and this is an example here where we started on the blueprints, as you see here on the left-hand side, and building this bronchoscopy suite that we established about 15 years ago. And we end up getting the state-of-the-art anesthesia machine, the same one we use in operating room, as well as space in the walls for our supplies and Pyxis machine and such. And once we start serving there, things went very, very smooth and safe for our patients. If you'd like to read some more about our experience, we published that here in 2022 in the journal Chest. Here's an article that we can see how we were able to accomplish such a modern bronchoscopy suite. And the process repeats itself in the GI suite, and you can see here a modern GI suite. Space is good enough. The lights and outlets and monitors and machines and such, same goes for the IR suite as well. So our involvement in the beginning of the process should help so much and tremendously in getting the space ready for us to practice safe anesthesia services, and will not be retrofitted in that area and become an afterthought, and then it will not be safe for us in any way, for the patient or for us, even just ergonomically, it will not be a safe endeavor. And many of you may agree with me that working in NORA has gotten to become a burden, and many hospitals actually divide that burden among their staff, anesthesiologists and nurse anesthetists and AAs and such. And because it just not because we are lazy folks or we do not want to work, but hard-working folks would like to provide services. That probably because many of us do not feel that we're providing our best care there or providing safe care, since we do not have what we actually need. We were able to reverse that narrative in our bronchoscopy in NORA by just doing proper planning of the space equipment. As I mentioned earlier, we have the same modern anesthesia machine they use in OR, the same equipment that we could possibly need, the same arrangement for things, even just in the drawers and such. All the appropriate resources are available, and simple things as the electronic anesthesia record is the same used in OR, and the main OR is used in the NORA location, and building the team together and the team spirit and such. That transformed this service from an undesired service into a top-rated desired service that now cannot meet the requests that people want to serve there. So one thing I want to highlight here is a similarity as possible to the main OR. And I'm referring here to the anesthesia machine, for example, where NORA is not the best place where we need to learn new knobs or use the retired anesthesia machine, the old one from the OR, which is it's just easy to break and have issues with it, and different than the one we use in operating room. this practice that has been in place for many, many years is now obsolete. NORA, where we now take care of sicker patients for very advanced procedures, is not the place to use the old anesthesia machine. It's not the place to provide anesthesia with not adequate monitoring or no supplies available for this patient. I'll give you an example here for this case, in IR or in a CAT scan, where a patient, 7-year-old, scheduled for cryoablation, left upper lung cancer. He has this history, as you see on the screen here, including AFib, COPD, and home O2. He had BK for lower limb embolism and alcohol abuse. And so this procedure is not common, so we're asked the procedures, try to learn a little bit more about what you're going to do and how you're going to do that. Turned out to be that he showed me that probe. So this probe here, I'm going to CT guided, put that into the chest, going through the chest wall into the lung cancer. And once we turn it on, it freezes the tumor around it. And when you turn it on in room air, the moisture in air became this ice here that you see in the hand with a glove. And as it turned out, it's not just one, and it's not two or three. It's actually ended up being 4 probes going all the way from the skin down into the lung where the lung cancer is, to freeze the cancer. And as you could see, this procedure could carry a lot of potential complications, like lung parenchymal hemorrhage, pneumothorax, hypothermia, loss of airway. Therefore, we have to be very, very prepared and deal with it with the utmost care and monitor. So in this case, I decided to go with a double lumen tube in case we get bleeding in the lung they're working on. We can ventilate the other lung. We put in our tear line, and as you know, this would require capabilities for invasive monitoring as well as capabilities of ventilation with a double lumen tube. Hence, the need for a modern anesthesia machine that's capable of providing such services. And as you see in all NORA locations, there's expansion, there's introduction of new procedures, new equipment. And I encourage you all, whenever you have a new procedure or new equipment coming to your area, try to do a dry run. Learn about the equipment, learn about the procedure, anticipate complications, and make sure that you are available and ready for things. Here's an example: the robotic bronchoscopy is coming to many bronchoscopy suites near you. Many of you started or have been doing EBUS and navigation bronchoscopy. Now it's another advanced way of bronchoscopy, the robotic bronchoscopy. This machine came to us looking like that. So we end up doing a dry run where we got a mannequin, attached the robot with a bronchoscope to the, as it turned out, it does attach to the endotracheal tube for it to be able to function. So we imagine what would happen if we have a bleeding or a pneumothorax. How we're going to detach the robot from the airway, who's going to be responsible for moving the machine away, and how we can do that in a timely and efficient manner that the anesthesia team as well as the pulmonology team can get to the airway and take care of this bleeding or pneumothorax. And do we have the equipment to deal with that? Do we have different treatment modalities for bleeding? Do we have different, like for them, chest tube or some for the pneumothorax? And also, if the bleeding is so much, how can we transfer the patient to IR for embolization, if you will? So we figured this all out. As you see, the whole team around the mannequin was a robot, practiced on this, and then when we did do all that, we end up practicing safely and providing these procedures. As you see, the N95 masks, and so this was done during the COVID pandemic. And the advanced ventilation technique that needs advanced and highly technical machine is needed for these protocols, because as we advance in the procedure, like doing this navigational bronchoscopy and such, we end up realizing that the little bit of atelectasis that ensues after the induction of general anesthesia make the procedure very, very difficult and not successful at all. Here's an example, this peripheral lung lesion, because we do navigation bronchoscopy and robotic bronchoscopy, as you all know, for peripheral lesions. EBUS is done for central lesions right around the trachea. But for peripheral lesions, we need the navigation bronchoscopy where the needle navigates blindly under the CT guidance to get to the peripheral lesion. So if the lesion is right there that you can see it was a lung fully inflated, it actually disappears in the atelectasis over there. It would make the procedure very unsuccessful. Therefore, new ventilation strategy has been developed and techniques to handle that. Here's an example in our recent article. We just published our own algorithm for doing that. Here it is. It requires using high PEEP and higher ventilation volume and so forth, and all the details are written here if you wish to review it from that article. But it does require to have a modern anesthesia machine that can deal with this and also deal with the potential complication, other variabilities that we have in the management of these patients. Now let's move to quality and safety, which is a huge thing in non-operating room anesthesia. That made us put a whole section on the new statement on how to handle quality, how to handle safety, how to improve conditions and situations to be able to provide a safe anesthesia. I'm highlighting a couple of things just to relate it to the topics today. One of the things is each procedure room, and please note when you review that statement, the words have been selected carefully. When we wrote about each procedure room, meaning that if you have a suite that has multiple procedure rooms, like a big giant suite of 3, 4, 5, 6, 7 rooms, each room, when it says each procedure room, so each room should have that, whatever it says in there. When we say within the bronchoscopy or NORA location, that means that if you have multiple 6, 7 rooms, you probably will need one difficult airway cart or one MH cart. But in each procedure room, you will need adequate monitoring equipment, including capnography. We highlighted that, not because we did not know about capnography, but we really needed to highlight capnography as it is an important thing. If you notice that the ASA standard for basic anesthetic monitoring in 2010 has changed to include capnography as a must. It's not and or. In the past, used to be or visual assessment of ventilation. No, it's actually in 2010. If you have missed it, it says visual assessment of ventilation and capnography as a ventilation monitoring. And also, we did not forget to write about the anesthesia machine. Anesthesia machine equivalent in function to the one in the main operating room. And I would add, not just equivalent in function, but I would say it's used similar to the one. It's the same machine. Again, providing service in NORA is not the right place to learn new knobs or to try different things. Dealing with these sick patients and high-risk procedures, we should not worry about other things like that. We should focus on the patient, on the airway, on how to manage and get them through safely without worrying about, am I doing the right things with the machine? Do I have the right equipment for this or that? We should have all those ready for our patients. I just put one slide about some of the data that we have now about safety in non-operating room anesthesia. This is a close claim article. And if you're not familiar with the close claimed article, those are the cases that went bad and there's been a bad outcome, end up going to litigation, and there was a payout for the patient or their family because of the bad outcome that they had. So those cases go into a database, and every now and then the American Society of Anesthesiologists, a group of the investigator, look at the database and analyze certain outcomes. They published 2 articles on the outcomes of airway management, one article about aspiration outcomes, and this one regarding NORA. As you could see here, that we know that we do a lot of bad cases in NORA. That's no surprise. But here's the deal. The respiratory events were actually more in NORA than in operating room. And many of them, unfortunately, were judged to be preventable, meaning that they did not need to happen. We could have prevented them by proper monitoring. Therefore, we highlight the word monitoring and especially capnography, and we need to have whatever we need in monitors in the NORA. I listed here an example of monitors that we should have. And as you see, if you have a modern anesthesia machine, you will have all these monitors in there, and you can apply them to the patient as you provide them. So let's switch gears a little bit, talk about airway management in NORA. And the principle we're going to talk about here also will help in other areas as well, like the MNOR and ASCs and office-based anesthesia as well. Many of you may be aware that the ASA issued the latest updates on the difficult airway practice guidelines. This is a group that worked on it. This was the one and only in-person meetings that happened before COVID, and I was privileged to be part of this group that put these guidelines together. So what's new? There are many things in the guidelines that different from the prior guidelines. I just put a couple of things here to related to our discussion tonight. There was new infographics. We never had infographics before. We only had the algorithm. This time we had algorithm and infographics for the first time ever. We issue pediatric algorithm and infographic. But the one main thing that we focus on, huge emphasis on oxygen delivery throughout the whole process of airway management, from pre-oxygenation, induction, maintenance to including extubation. New also, the group added human factors list to be considered in difficult airway management as we take care of patients in that modality. So one of the things that these new guidelines were specific for is that it applies to everybody in every location. Anyone providing anesthesia care, airway management, anywhere in the ED, in the ICU, in NORA, in ASC, in office-based anesthesia, NOR, inpatient, outpatient, you name it, it applies to all. And hence I'm mentioning some of the concepts here as we discuss NORA management. First, let's talk about human factors. These were divided into practitioner factor and external factor. And for the external factor, we had patient factor, environmental factor, and institutional factors. If you look at the interventional factor, airway equipment and monitoring. So before you even start managing the airway, you should make sure that you have all airway equipment that you could possibly need and all the monitors, including capnography, because nothing is better than capnography to document endotracheal intubation and to avoid esophageal intubation, if you will. And also if we're doing MAC, which is actually not a modality of anesthesia, by the way, it's a billing code or a service description of being there to provide whatever is needed to get the procedure accomplished, from nothing to moderate to deep sedation up to general anesthesia. And our expertise is that we're there with our expertise to make things happen, keep this patient safe, and get the procedure accomplished. So therefore, if we're doing different degrees of sedation, and what described as MAC service, then monitoring of the ventilation is of huge importance, as we have seen in the past that many of those cases were preventable by adequate monitoring if that was utilized. Airway management always has to start with pre-op examination, and this needs to be done by the person who's going to be managing the airway. The airway manager is the one should be doing the airway. Do not rely on airway assessment done by pre-op clinic, by another colleague, by somebody else. And I'm not going to here talk about Bell-on-Patty or cytomental distance or not. All of us now, if you've been practicing for a few years, you know trouble when you see trouble. I put here some examples. Kissing tonsils, for example. Here is somebody who exposed to radiation. This neck was flexed. If you see it from lateral, this was fixed, neck flexed, and have trismus, very small mouth opening. The status post flap and the mouth opening as you see it. And here's severe obesity with sleep apnea, small mouth opening, short side of it. And look at here the scan. The airway is so narrow back here. So you know that soft tissue could lapse, could block CBU totally. So these are some examples of difficult. When you see a difficult airway, it walks like one, looks like one, it is a difficult airway. The new guidelines had infographic. So the first part is it's something that new, which is a guide on how to make the decision, a decision tool, decision-making tool in managing the airway. Should we proceed with consider intubation or management of the airway after induction, or should we do that before induction? Simply put, if this patient has suspected difficulty in endoscopy, or intubation with direct or video laryngoscope? If the answer is no, you may proceed with management of the airway after induction of anesthesia. If the answer is yes, and then you look at the next step, is there suspected or history of difficult ventilation with face mask or supraglottic device? If the answer is yes, then you may want to strongly consider awake airway management. So you have difficult endoscopy, difficult intubation, and difficult ventilation, then yes. If you have difficult intubation and high risk for aspiration, if the answer is yes, then you may want to proceed to awake airway management. If you have difficult endoscopy, intubation, and increased risk of rapid desaturation, we're talking about high risk for aspiration, talk about somebody who have bowel obstruction, huge ascites, and somebody just had a meal for urgent or emergent procedure. Rapid desaturation, somebody was septic coming from the ICU with 15 liters and is a cannula or non-rebreather mask or 15 liters in a mask or an under-breather mask or high flow oxygen and rapidly and having sats barely in the 80s or something, they will not tolerate seconds of apnea unless you're really sure that you can get this airway in seconds. They may desaturate and end up being coding without having an airway. But also remember that any one factor alone, as mentioned here in this sidebar, can be severe enough or significant enough to warrant awake airway management as well. The last one here in the bottom, if the patient had difficult for emergency invasive airway access, like somebody had a tumor that's like occupying the whole trachea like a huge goiter, then there's no even chance for the backup plan, which is invasive airway. So those ones should be considered for awake airway management as well. So if you decide to proceed with induction of anesthesia airway management based on your judgment and your call, it has the airway manager as the one who did the airway exam, then the algorithm specify how would you handle the situation if you encounter difficulty. But please, before we even forget, look at this green bar on the side. It says provide oxygen, deliver oxygen whenever feasible through all the stages of the management. So if your primary airway intervention did not work, if you're a supraglottic airway or the endotracheal tube, you could not place that in place and work efficiently, then you have to decide, are we in the red zone? Is this an emergency or are we still okay based on the adequacy of ventilation? And based on that, you will decide where to go. So if ventilation is adequate, then you need to do either, you could awaken the patient up and try awake airway management or different technique or another day or something. You could use alternative device. If the LMA does not work, you can use a tube or vice versa. Or you can decide to do it since you're ventilating and doing well, patient is induced, then you can do elective invasive airway like tracheostomy, for example. But this time around, the task force decided to define the number of attempts for each device before you call quit on that device. So keep trying again, the same thing, trying getting different results, kind of definition of insanity type of deal. And the more attempts, the more complication one gets. So 3 plus 1, 3 by the primary airway manager plus 1 if you get a colleague who's experienced in airway or have many years of experience longer than you and want to try another attempt, they may be able to do that. If ventilation becomes difficult as you do that, or from the beginning, then you get into the red zone, which is the emergency pathway. At this point, you really, really need to call for help, and you start preparation for invasive airway. They found in the past in those close claims that bad outcomes happen when people delay the decision to get an invasive airway. But as you're getting a scalpel or you're around the corner, ENT surgeon is coming to help you out with the invasive airway, you should not quit. As we talked about, we have the green bar, provide oxygen by any means, nasal cannula, high flow, mask, whatever you can. That's one thing. But also keep trying with different devices that you haven't tried before, different techniques. You might be successful as you get things ready to do the emergency invasive airway to save the day and save this patient. Now, if you have decided to go for the awake airway management, and you see we have also the green bars. So the green bar is used for asleep airway management or awake airway. You have to deliver oxygen whenever there's an opportunity to do so with whatever device, with whatever technique you need to do so. And awake airway management could be awake intubation or could be invasive airway, awake invasive airway, awake tracheostomy. Again, you have to provide oxygen throughout the whole thing. And if the situation gets a little bit more murky and the first technique did not work, then you can call for help. Then it's to consider here, because the patient should be spontaneously breathing. It should be no acute risk, as with the other situation where patients already NTUs. This one is awake airway management, spontaneously breathing, so we have not burned bridges. You can always back off and consider other techniques and other items, as we have mentioned here. When the primary technique fails, you can always try alternative awake technique, awake elective invasive airway, or alternative anesthetic technique. Only if the patient is unstable, you may want to consider induction of anesthesia with preparation for /trach. So the Difficult Airway Society guideline, this is the Difficult Airway Society in England, issued guidelines for awake tracheal intubation. So in their recommendations, it apply high flow nasal oxygen early. So again, they share with us the need for oxygenation, while the ASA guidelines, they apply lower high flow oxygen, or any way you can provide oxygen. They were more specific, say high flow nasal oxygen, as folks have identified that this is a higher or superior oxygenation technique. Mindray, the sponsor of today's talk, have these advanced machine that they call anesthesia workstations. We're highlighting here A8 and A9 models, and they have this as in addition to all the high tech and the high end monitors and ventilator and digital vaporizers and safety features. They also have a side pole that to it connected the high flow oxygen machine. So you do not need to get in another machine into the OR. You can just plug in the tubing and provide oxygen right away. So that's another safety features that has a lot of utilities in the ORs as well as in NORAs. For high flow nasal oxygen, the highest use for it, I would say, is the procedure I find the most useful is during suspension laryngoscopy procedures. As you know, there are many techniques of doing those cases. You can do a spontaneous breathing technique, which I do not recommend. If you get to do suspension laryngoscopy, you better paralyze, because you could dislocate the jaw easily, and the cords will not be that open to proceed or stable to proceed. Intermittent apnea technique is workable, just cumbersome, and expose the patient to trauma of multiple intubation. Jet ventilation technique has been very successful and helpful over the years. I've been using those for years, and they're preferred because when you have no endotracheal tube, you decrease the risk of fire, since you do not have anything to catch on fire. You only have oxygen and the laser, for example, or the cautery, but you don't have anything to catch on fire. It gives better surgical access because the tube is not in the way. However, it's still an unsecured airway and the potential for aspiration risk. As you know, supraglottic jet ventilation could be done in many ways. Proximal, when you attach the jet needle to the eyepiece of the DIDO or the suspension laryngoscope, like in this picture, or and the devices we use as the manual jet ventilation, this one, or the electronic one, the so-called Monsoon. This one is very expensive. It's about $35,000. This one is like $150. You can buy it on the internet. I actually prefer the manual one, because you are attached to the patient with every breath. You can actually see what's going on with it. And you can do that also by distal jetting, when you can hook up the needle to this tube that goes along the needle to open up at the vocal cord level. You see here the jet tube attached to this tube here that goes all the way down to apply. However, With the high flow nasal oxygen, I found it to be much easier. You do not need the jet. You do not need to keep pushing on the manual, or you need to worry about the high cost of the automated jet. You just apply the high flow oxygen like here, and you go. You do not need to interrupt the case. Also, the vocal cords do not even move at all. If you use the jet, you'll see that the jet moves. So it is the setup. They are dilating a subglottic stenosis in this case with this machine, as you have seen it before. And here's the high flow cannula attached. Here's a picture from above. You could see the subglottic stenosis here that they're working on, and no jetting, nothing. The surgeon's working. And we use that with the patient paralyzed. So in a patient under general anesthesia with muscle relaxation, and the oxygenation, abdominal oxygenation is taking place with the high flow nasal oxygen. In this article, we shared our experience of 150 patients that they did extremely well with the high flow. And here we identify which patient works better for, like less than 30 BMI. For higher BMI, you might need to supplement with jet or intermittent intubation, for example. We noticed also that the CO2 rise up some by the duration of the procedure, but it's still tolerated. So ventilation happened to an extent, to a small extent, but not zero, but not a very effective ventilation, if you will. Again, the advantage of high flow over jet ventilation, this procedure is that easier to be trained on. You just apply the cannula and move on. No risk of bariatric trauma, does not cause vocal cord mobility, can be used pre, inter, and post-op. It's warm humidified gas flow, very comfortable to the patient, and does not dry out the airway. And it's very helpful with jet ventilation. Is challenging. And again, the automated jet ventilation is very expensive. The high flow is much cheaper. And after that, we start to see different uses for high flow. Some folks start using it during moderate sedation for bronchoscopy. Others have used it in EBUS for bronchoscopy, and they thought that it worked okay. And here's an example of a patient I used it. This patient used to always have difficulty waking up. This is a lung transplant patient, had difficulty waking up after lung surveillance and such. So she was kind enough to allow me to take a picture. We had the same difficulty with challenge this time, but this time we had the machine, the high flow machine. So we end up, and instead of keeping her intubated, admitting her to ICU, just keep her in this for 20 minutes, and she recovered well and ended up going home. And many other folks have used it in morbidly obese patients. In post-op, they tried to use that high flow compared to nasal cannula. They found that lower desaturations and less atelectasis with the high flow nasal cannulas and the challenging recovery patients who are obese. Some other folks used it in dental procedures as well. They found it to be helpful, and in colonoscopy as well. Here are some examples of its use in colonoscopy. I cited two studies for you. One case here, the other one is a randomized trial. But before we close the chapter on the high flow, I wanted to share with you that there was only one report of fire with this, because the three items that are required to have fire were present in this particular situation. They had the fire triad. They had the oxidizer, which is oxygen, the high flow. They had the fuel, which was this part of the cautery. The cautery blade was covered with plastic material, and the energy source is the cautery itself. So this piece caught on fire while they're doing this palate surgery. So when you work in the airway, if you don't have a tube, you don't have anything to catch fire, so that would decrease the risk of fire. However, the company does not recommend it in those situations. There's more data coming out. There's cadaveric study that was done. We're waiting to see the results of that one, where they tried different levels of high flow with different FiO2s with application of laser. And there's also some human data coming out of San Francisco at UCSF. I forgot the name of the university there, not UCS, Stanford. It's actually Stanford data that showed that they were able to take care of many patients that did not have fire when they used laser with a high flow. However, it's not currently recommended. That we'll get to know more data on that. But it has been helpful in areas where there's no energy being used in the airway, like in when we do dilation of subglottic stenosis. And oftentimes when we use it for lasering of the airway, during the lasering fire, we turn it off for seconds till they fire the laser and then go back on it. And that has been safe for us as well. So in summary, a reliable state-of-the-art anesthesia machine is a must in today's operating rooms. Equally important to have the same advanced machine in NORA for similarity, for comfort, for safety, for ability to be used in high risk and complex airway management or ventilation management, if you will. Again, familiarity and similarity equals patient safety plus superior clinician's experience. When the anesthesiologist, nurse anesthetist, certified anesthesiologist assistants go to NORA and they find a machine that they have been using in OR with the same setup, and if you have drawers in the machine set up the same way with alcohol and sponges and syringes and such in the same fashion, the same supplies in the main OR, the same there, and you have higher safety and ability to provide oxygenation in different ways with nasal cannulas, with masks, with high flows. Obviously, you're not going to use high flow for every machine, but for every case, but for certain cases and certain high risk patient, certain procedure, that might be a helpful technique to use, especially if you're doing awake intubation, somebody with high risk airway, or if you're managing somebody who potentially could benefit from it, then it would be a helpful technique to have, especially if it's something readily available attached to a machine like the one we talked about today. With that, I conclude my prepared slides, and I really intentionally wanted to end at 45 minutes to allow ample time for questions, and be happy to address those and answer them if you wish to write them in the chat or Q&A. And thank you for being a great audience and attending and listening to this presentation. Back to you, Shirley.
Thank you so much, Dr. Abdelmalak. That was really wonderfully detailed and just so well researched. So thank you for that presentation. And I know that you tailored it for us tonight to be able to ask questions at the end, like you just said. So we invite our audience members tonight to please go ahead and enter any questions that you have into our Q&A chat box at the bottom of the screen. While we wait, Dr. Abdelmalak, are there any other pieces that you did want to talk about tonight that are related to any of your slides that you might have some moments to touch upon, or any frequently asked questions that you get about these various procedures?
Sure, absolutely. One thing is, folks, for example, talk about how max sedation is better than general anesthesia in those locations. And that's kind of a common myth. Is actually not, and I shared with you earlier that how there are some many ventilatory and respiratory insufficiency events happen with MAC, resulted in poor outcomes up to death, unfortunately. So it's not safe. Safer, I would say. It depends on the patient, the procedure, the anesthesiologist or nurse anesthetist performing and taking care of the patient, their skills in managing that, and also the circumstances around them, their access to the airway, access to the head and neck. They will be able to decide and which technique would be the best for this patient, which technique would be the safest for this patient. The other question I get asked is that is direct laryngoscopy still the number one to be utilized in every area, or is video laryngoscopy has a role, or should we do all cases with video? So different ways of questioning which device should be using for airway management. And I just want to share with the group that there is now a trend towards using a video laryngoscopy as the first line or first device in intubation in both the routine airway management as well as the difficult airway management because it has become commonplace now to have video laryngoscopes available. The price has come down. The technology has gotten better, better screens, better lighting. And also we know that many of them are disposable blades, or the whole thing is disposable, so decreased risk of infection. And the cost has gotten almost comparable to the direct laryngoscopy. Now, most hospitals do not use reusable direct laryngoscopy. They use disposable one for the risk of infection. So that has become costly as well. So the cost has gotten close to it. Because of the superiority of the video laryngoscopy in visualizing the larynx and the higher success of first attempt intubation with video laryngoscopy, many societies now has been advocating for it to be used as first line, including our ASA guidelines. It's mentioned that every anesthesia location, if you look at the list of equipment that needs to be available in every anesthetizing location, it includes a video laryngoscopy and appropriate stylets. The Canadian guidelines go even further to recommend that we can and we should use, and I have done that myself, to use video laryngoscopy in awake intubation. So awake intubation doesn't have to be with flexible scope. If somebody is not very experienced with it, but they have a great video scope that they're very skilled with, and the patient is risky in terms of, as we talked about, the algorithm, difficult intubation, difficult ventilation, and you can pre-oxygenate with high flow oxygen or a nasal cannula or a mask, as you will, depends what level of sedation you're going to provide them and what level of comfort you have and anatomy and so forth. And according to the Difficult Airway Society, they prefer high flow. You can pre-oxygenate them with that, topicalize them, give them a little bit of sedation, and you can go intubate with video laryngoscope, and that has proven to be successful and helpful as well. So it doesn't have to be a flexible scope. Video laryngoscopy has gotten more of a role in the routine airway management, if you will, compared to the prior years. So these are common things that we hear about airway management questions, and those principles really apply to NORA. As NORA is you're not close to additional help or expertise from your colleagues, therefore it calls for us to be extra careful. So therefore, to have the proper equipment, to have additional safety features like having high flow available, having video scope available, having a difficult airway cart close by, that would be fantastic and helpful as well to help us managing those cases. So any other questions, please, that anyone has or placed in the chat or Q&A? I'm very happy to do.
Thank you, thank you so much, Dr. Abdelmalak. What I am seeing is a few more folks joining us, and we don't have any questions yet, but what I will say is for anyone who has recently joined us or came in after the presentation began, we will be emailing it out to everyone who's registered sometime over the coming week. So you will be able to see the wonderfully detailed presentation that Dr. Abdelmalak prepared for us this evening. In the meantime, we are still waiting. We still invite you to add some of those questions into the Q&A chat box. And I will let you know that I've also added the doctor's information into the chat for everyone to have in case. I mean, he has it here up on the website, but I've also added it to the chat box so that you can simply copy and paste it into your notes or wherever you like to keep this information, his contact information.
So as NORA expands and grows and we go to all these places around the hospital, we need to be really, really careful about how we schedule cases there. This is something I did not touch on today, but in the new statement from the American Society of Anesthesiologists, we advocate for using block time. For example, if an area has enough cases, you can, instead of giving them half a day every week, you can give them a full day every other week. That works much better than giving half days. If the suite is big enough and the volume is big enough, you can schedule things there as if it is an ASC or a small OR suite. But if you're only doing a few cases here and there, try to use the block time. And part of other things that will provide for efficiency is that they should use the same scheduling system, like if they're using Optime, or they're using Cadence or something, they use in the main OR. So as your the patient and the case show up in your electronic record, that saves a lot of time and makes it easy for you to document any patient. And also, when you use such systems, the case and the schedule will show up in the main board where you're running the whole hospital. This way, you're aware of where your personnel are at all the time, what stage of procedure they're at. This way, you can use your personnel effectively and efficiently. The other thing we have noticed, and we wrote that in there as well, is that you please do not allow and request from the procedures. Do not separate anesthesia cases with procedural sedation cases, because that's a downtime for our teams that they are not productive at. And if we consolidate cases, we can provide efficient service and use the team in another area or back to the OR as needed, instead of having downtime between cases while the proceduralist is doing procedural sedation cases that does not require anesthesia support. Pre-op evaluation is a common issue and concern for patient safety, especially in the GI area. So we encourage you all to work on a system where you can either pre-op the patient before you provide service for them, or use a pre-op anesthesia clinic, or use a system where the proceduralist can help with doing some sort of pre-op assessment and get your attention to the higher risk patients with severe issues like heart failure or ischemic heart disease or aortic stenosis or pulmonary hypertension, all these big things that impact what we do and may warrant a change in our way of managing those patients. The other thing that people ask about and talk about is PACU. It is not very safe to transport patients across hallways and different buildings and elevators and possibly cross the streets and the skyways and such if the NORA location is far away from the main OR pavilion and the main recovery room. So it is encouraged and recommended that those far location, or each NORA location, especially the big ones, should have their own recovery room. This way, you do not have to transport the patient a long distance, and the patient will be safer that way. But I encourage you all to be part of writing the policies. Writing policies for NORA or any place in the hospital is not a fun activity. I get it. We do not like it. We don't like to be involved in it. It takes time. We're busy folks, and it's not a fun thing to do, and requires a little bit of work looking at CMS and Joint Commission guidances and national guidelines and so forth, and wordsmithing and all that. I get all that. But if you don't do it, guess who's it's gonna fall into the poor nurse manager who's gonna feel obligated to write it down, and he or she may be busy, may not be able to look up all these things, and they're gonna end up write something that once it gets approved and passed by your MAC, you're going to have to comply with it, because the worst thing you could do when the surveyor come in is that you're out of compliance with your own policy, especially if the policy that what is written in there is something that you don't approve or you don't practice and you don't think is safe enough. So a better way to do that is to be involved in writing your own policies for those areas, and that would be helpful and safer to your patients. But I would start from the beginning. When they're building this areas in NORA, when they're establishing the, be in the business plan as they write it down. Make sure that includes a modern anesthesia machine, all the equipment that you need, a difficulty rate card for a remote area or multiple close by areas. You can have one for cover them all. Malignant hyperthermia card if indicated, if you're using inhalation anesthetics and suction colon in that area and such. So all these things you need to be in there. And if you need additional equipment, point of care testing, glucose or INR, or you need additional equipment like video scope or flexible scope, high flow, anesthesia machines that have high flow, like we talked about, all these things need to be included in the business plan, as well as FTE needed to provide the service as proposed. And it's a time to look at what is the predicted volume. What is the need in the community? Do we expect to get a lot of patients if we open this service area or expand it? And how many personnel we need to cover that area And as you consider FTE, don't forget the vacation and post call and all that, and the long hours of the day if that's the case. And always try to minimize over or underutilization, especially overutilization. Try to schedule the cases to end at the end of your daytime, not to expand to the wee hours of the night, and that's not preferred, especially in remote locations. I'm trying to summarize a few things, as I mentioned, from the statements and from what we thought of and from what we do in our hospital, as I've been practicing and leading NORA for many years. All these items and ideas have proved to be helpful and help us to provide a very safe care to our area and make it a desirable assignment for our staff.